is Stephen Lazarou. I am a reproductive urologist. I'm thrilled to join you this evening and provide a little brief introduction, go over some questions that I often get asked by my patients, but largely leave it up to you to ask the questions and do my very best to answer them with you. So I specialize in the evaluation and treatment of male infertility patients, including treatment of severe male factor infertility, fertility preservation for cancer patients, seeing men with low testosterone and sexual dysfunction. And additionally, I perform microsurgery of the male reproductive system, including and especially microscopic sperm retrieval for IVF pursuit. And there are several questions I often get asked by my patients. By no means is it exhaustive, but I'd just like to go through a few of them with you, if I may, and perhaps they'll overlap with some of the questions you may have this evening, maybe not. But I see a lot of men for male infertility who may also be using testosterone. So a common question that I get asked is, well, this testosterone that I'm on has really improved my quality of life and my performance. Can I continue with it, as my pursuit of fertility goes forward? The challenge is that most men who are on testosterone supplementation have reduced semen parameters. Specifically, most of them have no sperm in the ejaculate as a result of being on a testosterone. So for these men, and many of them are unaware of it, you can switch them to a medication like Clomid or even HCG, an injectable medication that can optimize and stimulate sperm production so that you can accomplish improvement in low testosterone symptoms and at one and the same time optimize sperm production. And then after fertility pursuit has been accomplished, these men can then go back on testosterone. So that's a common question that I get. To that end, a lot of men and people in general are taking over-the-counter supplements or stuff that they're ordering online. And oftentimes they'll ask me, well, is it okay to take them? And the answer is it's not clear-cut. A lot of the over-the-counter supplements don't really fall under the FDA approval. So it's unclear about the quality and, quite frankly, the quantity of substances in the supplements. And in fact, many of them do contain testosterone type substances. And a lot of these men are unaware of that, and that may actually have a negative impact on sperm production. So there are a few that we typically recommend that are high quality. So men do have options there. The other thing that we oftentimes get asked as reproductive urologists is that even before coming in or often upon their workup in the office, they're diagnosed with a varicocele. And a lot of men are unaware of what varicoceles are. They're basically enlarged veins in the scrotum. Very, very common. Probably 20% of the general male population have them. And the majority of men do not need these to be treated. But there are indications to treating these enlarged veins. For instance, if a man has recurring scrotal discomfort from the enlarged veins, and that's clearly an indication to consider treatment. Some men, especially men in adolescence or in their early 20s, may have such a large varicocele that they develop shrinkage or what we call atrophy of the testicle. And that is also an indication to consider treatment. And then for the majority of men who get evaluated, they're oftentimes referred because of reduced sperm concentration or motility, and they'd like to improve that with treatment of the varicocele, and that's reasonable as well. But you really have to look at the overall picture because there are oftentimes coexisting factors such as the partner's ovarian reserve, age, and other factors. So just because a man has a varicocele doesn't mean it automatically can or should be treated. You really have to look at the entire picture and individualize treatment. Another question that I oftentimes will get asked is in men who may have fathered a child at one stage in their life, and now with their partners, they're having difficulties, or with a new partner. And so oftentimes they'll ask, well, what is causing this lowering of my sperm numbers? What did I do differently? And it's a very good question. Sometimes there is an identifiable factor that's contributing to the reduction in semen parameters, but it's also possible that men's sperm numbers may have been similar at the time of their original conception. Having a normal semen analysis does not always guarantee fertility, but alternatively, you can have suboptimal semen parameters, which may still be adequate for contraception. So it is important to see a reproductive urologist to have a complete evaluation and sort that out. Another question that I get asked commonly are, what can I do to improve my sperm production and sperm quality? And certainly there are things over which you have no control, like genetics or other factors, but there are things that you do, such as pursuing a healthy diet, lifestyle, exercise, avoid smoking and drug use. And I know it's not easy, but try to manage the stress, because that certainly is a huge component for men's health and the couple in general. So those are probably the most common questions that I get. Hopefully that's a little bit helpful for you. And now I'd like to answer the questions that are arising here. So there's a question here that says, no way to understand the quality of sperm more with the right count of genes. We did 3 rounds of ICSI with 60 plus eggs and did TESI for the final round. Anything that you would recommend? Certainly 3 rounds of ICSI is a lot, and did TESI for the final round. Assuming the TESI was successful and sperm was retrieved, if that sperm was used for ICSI, that's really the optimal way to go. I think that sometimes, despite these approaches, you have to consider other options. And certainly it's worthwhile to look at egg factor in terms of quality, as well as the quality of the sperm, and have a further conversation about some alternative options. Next question here that I'm seeing is, does sperm quality reduce with age? Is there any sperm quality test? Sperm quality in men as they get older, there are changes in semen parameters. Oftentimes the volume of the ejaculate will decrease, and the motility can also decrease. And there's some evidence that aging males may as well have chromosomal issues. There are some higher rates of genetic issues that may be passed on. They're looking at increased rates of autism and other conditions that may be associated with paternal age. But it certainly is a hard thing to test for. There are sperm DNA fragmentation tests that can be performed. And that's more to the effect that it can help to stratify care of couples who are really trying to consider whether or not they want to pursue fertility either through natural attempt or with intrauterine insemination or IVF. But ultimately, it's a tough thing to test, and that is a challenge. There's another question here. I am 42 years old, and my wife is 40 years of age. In the last 2 years, we are trying for a second baby and unable to conceive. Does one recommend IVF? Well, certainly IVF is a strong consideration under those circumstances. It certainly depends on the full evaluation of the male partner and the female partner. Advancing maternal age does play an impact on successful natural conception. But furthermore, in a 42-year-old male, at least 20% of the time, there is a male factor that may also be contributing. So I think it's important the entire couple be evaluated, the male by a reproductive urologist if there's an abnormal semen analysis, or if there are other factors that might be putting that patient at risk for subfertility. Next question here. Are there general ranges for how long a sperm deposit may last if frozen or stored otherwise? Generally, no. Sperm can be frozen both in the short term and long term. And generally, if they are of a reasonable quality or if the sample is of reasonable quality, it can be stored for many years and then thawed out at a later age and still be of very good quality. Are there changes in my diet that I can make to improve the duration of the deposits? You know, as I said before, I think a healthy diet is really the best approach. I can't really recommend a specific diet that would improve your semen parameters. I think plant-based diet is mostly a good thing, and certain supplements. But I think a general healthy diet, nutritious diet is really the best answer there. Another question here suggests that with microdeletion, is ICSI the only option? So I think that question speaks to the fact that this is referring to a man who has either Azoospermia, meaning absent sperm in the ejaculate, or a very low sperm count, in which case a Y chromosome microdeletion test is ordered. And generally, if they are azoospermic and they've had a successful sperm retrieval, or if they have severely diminished semen parameters, typically IVF with ICSI is the best approach. Okay. Next question here from Tom. Are there any supplements or lifestyle changes that have shown evidence to improve sperm morphology? Very good question. I'm afraid there's no clear-cut data from the literature or in my experience that can really improve sperm morphology. Certainly, morphology is routinely tested. There's a fair amount of controversy in terms of sperm morphology, and the data is really sort of all over, regrettably. However, I think there's general consensus that if there are sperm with significant head defects that have impaired acrosome reaction, those are sperm oftentimes that can't penetrate the egg effectively. So IVF, and oftentimes IVF with ICSI, is necessary. Having said that, there are many men who have abnormal sperm morphology or abnormally shaped sperm who are able to conceive naturally. Next question here. My husband was diagnosed with azoospermia. They found no anatomical issues, no blockages or genetic issues that could cause this. What could be the cause of the azoospermia, or is there any way to fix this issue? They did mention sperm extraction to see if they could extract any sperm. What are the chances of sperm being extracted? So unfortunately, this is a pretty common scenario. There's a fair number of cases where it's idiopathic, meaning that we just, as physicians, clinicians, we just can't find a reason. When things are more clear-cut, in other words, if the testicles are small in size, if the blood work indicates that the FSH is elevated, which is a pituitary hormone that stimulates the testicles, indicating a production issue, then we call that non-obstructive azoospermia, for which we usually avail to doing an attempt at sperm retrieval, doing what's called a TESI procedure. But there are men who have obstructive azoospermia, meaning the testicles are producing sperm, but it's like a car with gas and no highway. So you can go in directly and extract sperm for IVF. When you're talking about the first, which is the non-obstructive azoospermia, the chances of finding sperm with microscopic sperm retrieval attempt, what we call microtesting, ranges from about 50 to 60%. If there's an obstruction, let's say like post-vasectomy or some other ductal obstruction, then the chances of a successful sperm retrieval are very, very high, ultimately leading to IVF. Where it becomes unclear, and I wish we had better ways of determining this in advance to try to avoid surgery on men, is that some men have a really normal anatomy. Their testicles are a normal size and shape. Their blood work indicates relatively normal overall balance with a normal FSH. Their ultrasound imaging can't identify any enlarged veins, cysts, or blockages. And even about 30 to 40% of those men with otherwise normal picture may or may not be producing sperm. So there's a range there. Overall, most men have a successful outcome, but it's hard to know, and hopefully we get better predictive tests. Next question here from Kristen indicates that her partner has a semen analysis which shows no sperm. He's going to do another sample. Should I freeze my eggs in the meantime until we can figure out the situation? I don't think you have to, unless, of course, there are other factors for which your reproductive gynecologist is recommending that you freeze eggs. In other words, there may be a situation where time is of the essence or other health concerns that would require or recommend you to freeze eggs urgently. But I think you have to look at the overall picture and then answer that question. Next question here is about what one can do for a low sperm count. Well, I think it's important, getting back to what I was saying before about being evaluated by a reproductive urologist, to see if there's an identifiable and correctable male factor. We do see that in about 50% of men, where we can identify a factor and correct it. Sometimes it can be due to certain medications or supplements or toxic exposures that are identified and then removed, and that may improve the sperm count over time, like testosterone, like certain prescription medications. Sometimes men have an issue where their testosterone production is low, and they may respond very well to a medication like Clomid or HCG. Or, as I mentioned, there's a certain number of men who have varicoceles for whom they might benefit from varicocele treatment. So there are some options there, and it is correctable in a lot of situations. And in the event that it's not correctable, fortunately, we're living in an era where we do have assisted reproductive technology, intrauterine insemination, IVF, which really work very, very well. In terms of the next question here, what are the possible reasons for a zero sperm count? Well, it starts with making sure that the semen analysis was produced and analyzed appropriately, that the sample was analyzed within an hour of being produced, that no lubrication was used, that there was a proper abstinence period of at least 2 days. And then if the sample was otherwise collected properly, we usually like to get a second semen analysis for confirmation. And then once that's been determined, then evaluation by a reproductive urologist, including full review of the history, physical exam. So the physical exam consists of evaluating secondary sex characteristics like body shape, distribution of body hair, evaluating for any enlargement of the breast tissue, which we call gynecomastia, and then focusing in on testicular exam, genital exam. And that evaluation includes evaluating the size, shape, and consistency of the testicles, palpating the cord structures to make sure the vas deferens tubes are palpable, And then also to evaluate for any enlarged veins, cysts, or rarely a mass. And then having lab work. Specifically, all men really get endocrine lab work to check their pituitary hormones, LH, FSH, prolactin, TSH, all of which help or are involved in the regulation of hormones in the body, including thyroid and testosterone production. And then typically we get genetic tests as well for men who have zero sperm in their ejaculate. Genetic tests are oftentimes ordered, and then imaging where appropriate. And then once that decision, or once that evaluation is completed, I should say, then a decision is made as to whether or not it makes sense to try to proceed with doing a sperm retrieval procedure, and if necessary, even reconstruction if there's a blockage that can be identified depending on where it's at, and then ultimately pursuit of IVF or ICSI. In the rare circumstances where sperm can't be procured by a procedure, then couples also have the option of donor sperm or adoption. Next question here, is sperm freezing using paid over time to retain it in storage, or are there one-time payment options? Well, that really depends on the fertility center. Most cryopreservation centers will charge an initial analysis and freezing fee, and then you decide with them based on how long you want to freeze it for. Next question here is, my semen analysis is normal and my wife's results are also normal, but we've not been able to conceive since 2 years. Are there some other male tests that should be done, or is IVF recommended? Well, I think if you've had 2 semen analyses that are normal, that's generally a good sign. But men can have normal semen analysis and still have fertility issues. Sometimes, as I said, they can have a hormone imbalance and they may or may not have symptoms. They may be exposed to certain medications or other things that may be affecting their fertility. And a fair number of men with the stress of fertility or just in general may have difficulties with erections or premature ejaculation or difficulties reaching orgasm with intravaginal ejaculation that make things difficult. And certainly timing and duration of intercourse play a role. So I think being evaluated by a urologist makes sense to make sure that, you know, all parameters are looked at. Next question here. To what degree does varicocele repair improve chances of conception for someone with low count and poor morphology? And does it have any impact in the case of using IVF with ICSI? So I mentioned at the outset about indications for varicocele repair. It does improve the sperm concentration and motility in the properly selected male. But one also has to keep in mind that it doesn't happen overnight. The majority of men, depending on the studies, you look at up to 70% of men within 3 to 6 months, but it may take up to a year, do have an improvement in their sperm concentration and motility. The impact on poor morphology is really unclear. And in fact, the American Urologic Association guidelines do not recommend repairing varicoceles in men who only have low morphology, but certainly if they have a low count and motility, it's reasonable. If a couple really is at the stage of IVF with ICSI or ICSI, then really varicocele repair may not be appropriate for this couple. Having said that, there are studies looking at sperm DNA fragmentation before and after varicocele repair with improvements in sperm DNA fragmentation. But generally, if you're at the point of IVF with ICSI, I don't think you have to do a varicocele repair unless your goal is to try to improve the semen parameters in the longer term and have the option, assuming no other factors, of not pursuing IVF in the future. Next question. Trying to conceive after sexual activity and masturbation, at times it seems there's a blockage when I urinate, even many hours after sex or the next morning. It causes pain that seems to feel like a urinary tract infection. Even just during normal, non-sexual routine urination, there seems to be a less steady stream of urine. At times, it feels like blockage. Is this common? And the answer is, it is common. So the testicles themselves make all the sperm. However, the testicles make only a small amount of the fluid in the ejaculate. The lion's share of the fluid of the semen is produced by the prostate and the seminal vesicles. So men can have inflammation of the prostate or seminal vesicles or blockages of the ejaculatory duct that may create some of the symptoms you're describing. Furthermore, the semen passes through the urethra through which urination occurs. So men can develop blockages or strictures of the urethra unbeknownst to them. They happen more commonly in men who may have had a history of sexually transmitted diseases or have had urethral trauma or catheterization. So it's important that really this individual has the reproductive tract evaluated by a urologist to A, improve the quality of life, and C, if there are ways to improve semen parameters as a result. Next question here. I have a low sperm count and poor morphology that's unexplained. What are some options? Well, again, I think meeting with the reproductive urologist, having full history taken, the history involves knowing whether or not this is primary or secondary infertility. Are there any medications that this individual is on, any exposure to other agents, any pediatric history of hernia repair, undescended testes, testicular cancer, is there any family history of male infertility, and a detailed discussion of sexual habits and any challenges there, physical exam, lab work, and imaging where appropriate. And then once that's all completed, to have a better perspective, hopefully, as to why the semen parameters are low. If one has low testosterone and then goes on Clomid, does this help with sperm morphology? I'm afraid the data is not clear on that. I personally don't prescribe Clomid for the purpose of improving morphology. With the boost of testosterone with Clomid, oftentimes we see an improvement in the volume of the ejaculate, the sperm concentration, and oftentimes the motility. But this really depends on a lot of factors. Morphology is really a tough thing to treat, tends to create a lot of stress and anxiety, and regrettably, we don't have great answers for why it occurs. We rather rely more on assisted reproductive techniques to help couples. Another question here. My husband has a low sperm count. We have been fortunate to have success with IVF in 2016. Congratulations. We'd like to have more children, but as self-pay patients, we're wondering if we would be worth looking into causes of the low sperm count, or is IVF really our only option still? I think that that being evaluated by a reproductive urologist is very, very important to see if there is a correctable male factor. And I think it's an important investment as you desire to have more children, especially if there is a correctable male factor. And a lot of the information really can be gleaned, as I said, from history, physical examination, and lab work. And then making a decision as to really what your options are there. During IVF, what is the most clear indication that sperm is the issue or is the primary problem? Well, I think oftentimes the quality of the sperm you know of before IVF, and you certainly have a sense of female factor as well. So it really depends on the preoperative evaluation, but oftentimes there's situations with IVF where it is less clear, and there are additional tests that reproductive gynecologists can do to help clarify that as well. Are there urologists we can schedule appointments with at Boston IVF? Absolutely, and happy to work with you, and we can give you contact information at the end of the session. Next thing here, it seems like a pretty misunderstood thing, male infertility, that is. Would you agree? Do you think there will be more research and insight into the future? I think you're right. I think there's a lot about male infertility and fertility in general that really is unclear. It remains to be elucidated. There's a lot of great research and good people working on coming up with answers and solutions. Fortunately, as I said, we do have technologies that can really help couples, even though there's a lot of things we don't understand. So we're very optimistic. Let's see, next question here. My husband is diagnosed with a varicocele. His urologist suggested to do the surgery after we've had 2 failed, I think it says IVF or ICSI cycles with abnormal monosomy and microdeletion. Should we start his fix first before our next cycle? It's certainly reasonable to have that conversation with your reproductive urologist. That may be an option, but really have to look at the entire picture there. I have issues with ejaculation with vaginal sex, but able to ejaculate when I do masturbate in prone position. We are trying to conceive. What should I do to fix my issue? Well, this is not an uncommon problem. You're not alone. Certainly at the start, you have the option to freeze a sperm sample that can be used for assisted reproduction. One could also masturbate and produce a semen sample and move directly to intrauterine insemination. But I think it's very important to explore why this difficulty is occurring and try to sort out with the urologist how much of this is physiological from psychological, and we've got very good tests to help differentiate that and great support, so I'm optimistic for you. Another question here, I've seen some serious side effects of Clomid medication. In your professional opinion, are these side effects common? Serious side effects are not common. You know, there are some men who develop headaches, or blurry vision, or sweats or hot flashes from Clomid. Those are really few and far between. There's always the potential for more serious side effects, but they are rare, and the majority of men respond very, very well. This medication has been around for several decades, very well tolerated for a majority of men, so a medication that I use a lot. Another question here. My partner was born with congenital bilateral absence of the vas deferens. Has there been any recent medical advances in reconnecting it so we can have children naturally, or will we need IVF? I'm sorry to say that at this time, we do not have the technology or the ability to reconstruct the entire vas deferens, because oftentimes, not only is the tube itself affected, but also a portion of the seminal vesicles and other structures. So we aren't able to recreate that highway. So at this time, we extract sperm and we pursue IVF. That works well for the majority of men. Okay. And another question here, can you treat hypogonadism and will it improve sperm production in a male with azoospermia who also has high FSH and high LH levels and normal testosterone? So in plain English, that's a man with absent sperm in the ejaculate, and the pituitary gland is already telling the signals to the testicles to make more FSH and LSH and try to tell the testicles to make more sperm and testosterone, essentially. It's controversial. In fact, most reproductive urologists, I can't speak for all, don't really recommend Clomid under these circumstances because the data isn't clear that if the FSH is already high, that boosting it higher will really have any significant shift in testicular production of sperm. This is an area of controversy, but it's of limited use, I think, in this scenario. So I think that we may be past our time here in terms of questions. So I just wanted to thank you all very, very much for your excellent questions here. And I know that there are more questions out there, and I appreciate how important they are. But it's really been a privilege to talk with you this evening. Certainly, I am available to meet with any patients or couples who wish to be evaluated further, and we can provide you with contact information at the end of the webinar. You can also go to my website at bostonurology.com, all one word, and contact me that way. And my office number is 781-237-9000. Again, thank you so much for joining me this evening, and I wish you all the very best in your fertility pursuit. Thank you, and have a good night.